Rajendra, start.
I think better will start. Suresh, Ilinda, I'll try to screen record try Martin. Ilinda.
No, it is on live now.
Okay, okay. So I think we'll start. I think.
Okay, 1 ನಿಮಿಷ. Yes, ಹೇಳ್ಬಿಡಿ ಲೈವ್ ಇದೆ ಇವಾಗ. It's going live.
I'll put it full screen.
Rajendra, ನೀವು ಸ್ಟಾರ್ಟ್ ನಾನು ಸ್ಟಾರ್ಟ್ ಮಾಡೋಣ.
ಮಾಡಿ.
Okay. Good morning, everyone. My name is Suresh from UK. I would like to welcome you all for this today's session, international webinar under the banner of GINA, Global Indian Nursing Association. I would like to give a brief introduction about the GINA. GINA is one of the association experienced nurses who all come from India. We are all made a group together to, whatever we learn from here, that we will give back to our own country. So that was our intention in this program. We are all nurses. We are all working for on and off shift and day shift, night shift, but still in that duration we are all dedicated to provide a online platform. So I think somebody needs to mute, please. So first of all, I would like to welcome our today's speaker, Mr. Tippeswamy Bilahalli, and from UK, and also Rajendra Irani from Ireland. So I will hand it over to you both guys. Thank you.
Thank you, Suresh. Good morning, everybody. Today, we're going to talk about medicine administration and management. So there are two aspects of medicine. One is the administration side, and the other one is the management side. So I'm not sure there is an existing policy that is there in your workplace. So it's important to have that policy in place to ensure that the safe practice is carried out in your clinical settings. Rajendra, can you make it a full screen, please?
It's a full screen.
Okay, right. Okay, so like I said, medicine administration and management needs a evidence-based policy in place that need to be reviewed and regulated on a regular basis through the hospital joint formulary and prescribing committee, and or someone who is in charge of the hospitals, especially the nursing director, the pharmacist, or somebody who's leading on the medicine side, or clinical directors. So these are all responsible persons for managing this policy within your clinical settings, and ensure that the training and assessment takes place to ensure that there is safe practices carried out in your clinical areas. Okay, next slide, please. Okay, so in this session, we're going to talk about how do we regulate medicines and how do we do evidence-based management, medicine management practice. We talk about briefly touch about pharmacological principles of medicines, although it's a vast area. We may not be able to cover all of it, but we'll touch some of it. We'll be able to how do we educate our patients in terms of their medications? How do we provide them the unbiased information so that the patients can make their own decision on whether to take the treatment, accept the treatment or not? And also, if needed, we need to be able to obtain a full comprehensive medical history of the medications as and when necessary. Next slide, please.
Sorry, can you check with the audio? Is in the hall? Is it okay if everyone can hear you? Please.
Babu, is it, are we audible?
They are muted.
Are we audible?
Yes, we are audible.
Okay, good.
We
Thank
can
you.
hear you. We can hear you.
Thank you.
And how about the screen? Is it okay? Is it in full
As
mode?
it is fine. Yeah,
Okay, good.
Thanks, sister.
Good.
it's
Thank you.
visible. No problem.
Okay. Right. So let's talk about the medication administration. So what is medication administration? When it comes to administration, the reason we administer medications is either for diagnostic purposes or treatment purpose, to cure an illness or prevent an illness or to promote health. So who administers the medications and under what guidelines? So the administration means it could be in an application of medication in any kind of form. It could be an injection, it could be inhalation, or it could be ingestion or in form of a tablets, or even topical eye drops, or whatever that for that matter. By who? By a person who is legally certified to administer those medications, so in most circumstances, it's going to be the qualified nurses who administer the medications. Under some circumstances, the qualified nurse or a registrant can authorize somebody else who is competent enough to administer the medications under their own directions. For example, sometimes we do ask the student nurses to administer medications, but you have to be responsible for making sure that the student nurse is competent enough to carry out that task when you are assigning that task. So it's although the student is administering the medication under your direction, ultimately it's the qualified nurse's responsibility to make sure that the student is competent, and you take the accountability for whatever the action the student has done for that matter. So that's the medication administration part of it. Next slide, please, Rajendra. So what is medicine management? So medicine management is evidence-based practice, the safe and clinically effective and economic use of medicines to ensure that the people using the health and social services get the maximum benefit from the medicines that they need, while at the same time minimizing the potential harm. So essentially what that meant is, so you need to make sure that it is safe. Next slide, please, Rajendra. So ensure that the medication is safe and it is tolerable and it's effective in terms of treatment wise, and it is cost effective in terms of affordability, and also it causes less risks, provides more benefits than risks. So like any medications for that matter, has every single medication that we take has got side effects. So we need to weigh the risks and the benefits. So when you are administering the medication, we need to be making sure, it could be a simple paracetamol for that matter. If you are giving a paracetamol to a patient who's got a liver problem, then we are then it's not really ideal. Sorry, excuse me, I need to admit some people in between. Okay, so sorry, somebody's blocking my screen. I had to wait for that to clear. Okay, so making sure that the medicine is safe, tolerable, effective, and it's cost effective, and also it causes less damage and provides more benefits to the patients in terms of therapeutic therapy or prevention of illness or promotion of health. So while doing so, we need to be able to, Rajendra, somebody is blocking me on the screen.
No, I can't.
I'm trying to admit somebody called Rijwan.
Oh, no, already that person is admitted long before.
But he's blocking the screen now.
Even John, you close it. Close one. Switch it on.
No, probably it's not him. It's his screen has frozen on. Okay, anyway. Um,
It's on YouTube as well. If anybody would like to watch on YouTube, always you can log on to the YouTube and you can watch on that, please.
Okay. So essentially, medicine management includes giving unbiased information to the patients regarding the medications and treatment, supporting practitioners and patients to make the best use of the medicines, minimizing the harm caused by the medicines, developing local guidelines and optimized management conditions, communicating with local hospitals and trusts. Next slide, please. Okay, scope. When it comes to scope of medicine management, so who is involved in the um, who are the parties that are involved in the medicine management or medicine administration? Anybody who is directly or indirectly involved in handling of medication, administering of medication, prescribing of medication, or dispensing of medications. So every single party, whether it is the clinical director or the medical director of the hospital, nursing director or nursing superintendent, staff nurse, a student nurses who are and porters, every single person who is directly or indirectly involved in the handling of medications are responsible for making sure that they are aware of this policy and there is a system in place to ensure that the safe practice is carried out. Especially when you have a newly qualified staff who comes into the trust or the hospital, it's a responsibility of the senior management team to ensure that training and adequate training is provided to those new staffs to ensure that they are aware of the policies and they make sure that they adhere to the medicine management policy and administration policies. Rajendra, over to you for the next slide.
Thank you very much. Before we proceed further to the more slides, I would like to clear one thing. So we are not going to mention anything regarding the administration of the medication. That is the techniques of administration we are not going to cover, but we are going to cover the policies and the legal requirements behind the administration of the medications we are going to cover today. So in this one, mainly I'm going to focus on the 12 themes of administration of the medication and also 10 rights of drug administration. So till now we used to study regarding only the 5 rights of drug administration, but now it's changed. Few of them they are saying it's 12, few of them covering 8 administration, but ideally it's 10 rights of drug administration, which we are going to cover in today's presentation. So before that, I would like to cover the 12 themes of administration of medication. Among that, the first one is patient have a right to receive their medicines from a nurse or a midwife who understand the purpose of the drug regime and associated risks and benefits. You should support the patient in taking their medicines safely within the collaborative approach. So what it means, every patient whoever comes under your care have a full right to receive the medications only if you know the purpose behind the medication administration. So that means in the sense every patient have a full right to receive the medication from the competent nurse only. Second one is you must be aware of the legal and professional responsibilities and accountability with regard to the medicine management to ensure the patient receive the maximum benefit from their medicines. And third thing is medicines are ordered from pharmacist or other authorized source. Once they have been prescribed for the patient should receive and handle according to the local policies and procedures. I'm not sure exactly what are the policies are there in SS hospital, but in Europe, how it is missed, once the pharmacy dispenses the medication, we can't hand it over to the patient. So that should be secured and locked in the medication press or in the medication trolley. And at the right time only, we have to administer the medications to the patients. Except inhalers, nothing should be kept near to the patient just for the safety reason. And the fourth one is you must understand the purpose of prescription or medicine order. Be absolutely clear as it is written or printed direction and seek further information. Fifth one is you are accountable for all actions and omissions related to your role in administering prescribed medicine. So as Tipu Swami has mentioned that even though student nurses are administering the medication under your direction, but at the end of the day, you are accountable for the administration of that medication. And if you are not given any medications to the patient, always there is a reason for that. We have to document in the notes. So if you are not giving any medication, there should be some valid reason that why you are not given the medication. And if you're purposefully, if you're not giving the medication, which causes the harm also, then you are accountable for that action. Then theme 6 is following the administration of a medicine, you should monitor the patient's response. For example, patient comes with a severe pain and you are administering the medication. It is a responsibility of the person who has administered the medication to evaluate the effectiveness of those medication. So if you're given the pain medication, analgesics we are given to the patient, when you're giving, the pain score may be 10 out of 10. So after half an hour again, you're reevaluating, you should assess, okay, what is the pain score of the patient, whether medication is working or not. If it's not working, so you have to step up to the next level of analgesics. If it's working, yes, continue to monitor. And if whenever it's required, give the further analgesics. Theme 7, you may decide to withhold the medicine based on a specific clinical rationale. For example, if the patient is on antihypertensive medicine and blood pressure is extremely low, for example, 90/60, in that case, it is completely advisable and understandable. Yes, you can't administer the antihypertensive medication when patient already in the hypotensive stage. So you are withholding that medication, giving the clinical rationale, and you are documenting the same in one of the nursing notes to cover legally. Next one is you must adhere to the requirements of the Misuse of Drug Act and regulation. This is most important thing, but unfortunately we won't be able to cover that one completely because we are not completely aware of the local policies in the SS hospital. Once we'll get that one in the future, we may correspondence more in relation to that one. Next one is you should have a thorough understanding of the factors involved in the medicine safety. You must recognize the importance of reporting every medicine related error. So this error can be actual or potential. So any error, for example, if you administer really wrong medications to the wrong person, you should be transparent, honest, and accountable. So if something goes wrong, yes, mistakes will happen from everyone, no matter who is that in the world, everybody will commit the mistake. But accepting that mistake and correcting that mistake through the incident reporting. Incident reporting is not to blame anyone. It should be a no blame culture. It is mainly to prevent the same mistakes to happen again in the future. So I may administer some medication, wrong medication to the wrong person because my work pressure is extremely high because of the shortage of staffs. I was not able to cope, so I administered wrong medication. So you are going to give that reason in your incident report why it's happened because of the extreme work pressure. So that will be highlighted in the incident reporting committee. Then they look into that one. Yes, they need additional staff there to carry out the medication administration safely. So they may look into that one and they prevent the similar error in the future. So if anything goes wrong, it's not because of your own. It's not completely unintentional mistakes. So that can be avoidable easily in the future. Second one is that third last one is you must understand the rationale for the drug prescription and potential adverse reaction of the drug in order to be able to identify. So any medication you're giving, always you have to keep in mind, you should be aware of the side effects of the potential side effects of each medications. That is most important as a nurse. So if you give any medication, even the blood transfusion also, if you're giving to the patient, yes, 15 minutes, you need to check 15 minutes before, 15 minutes after the administration commencement of the blood transfusion, you need to check the vital signs of the patient, especially early warning score. You can see whether is patient showing any signs of the blood transfusion reaction. Yes, immediately we'll stop it. So you know that what are the signs and symptoms you need to monitor in the patient. If you give the same thing, now the COVID vaccines, most of them you are getting now, from 16th, it's launched now. So once we give the vaccination, we are going to keep the patient for half an hour under observation, and you are going to see whether the person is going to develop any side effects or not. So to observe that side effects, you should have the knowledge of what are the expected side effects. That's what is in this theme will be covered. Next, theme 11, you must work with the patient where appropriate. Basically, it is a collaborative approach for the patient. It's not only the patient, doctor who prescribes, the nurse who administers, the patient who receives, the family who supports. It's a multidisciplinary approach. So at the end of the day, it's a collaborative approach, team level. And whereas the last 12 theme is you must understand the complex factor that influence the patient decision-making process. This is one of the beautiful theme which we'll be covering at last in the last sessions. We'll be going to cover this one. So in this module, we are going to cover, we divided the whole topics into the 4 categories. One is applying the medicines regulations. Second one is principles of pharmacotherapeutics. Third one is safe and appropriate administration of medicines. Fourth one is supporting the patient with patient education. And the last one is medicines history. To be honest, this whole presentation takes 3 to 4 hours. But because of the time restriction, we are going to skip few slides in between, and also we are not going to cover the topic 2, that is the principles of pharmacotherapeutics. And if anyone is interested, we'll send the videos and the related study materials to their emails. So please contact us. So what it covers. So topic 1 covers regarding the medication regulations, especially in India. What are the existing regulations in India and how it will affect your daily practice in nursing? Principles of pharmacotherapeutics. I'm going to skip that one and we'll come back to that at later stage. So what are the legislations are available in India now at the moment? But whatever the medications you are administering, it can be simple paracetamol, it can be IV fluids, any medication you're administering to the patient. So it covers under the 3. One is legislation, and professional regulators, and the policies, procedure, and protocol, and the PPGs in your local hospital. So professional regulators such as Indian Medical Council, Indian Pharmacy Council, and Indian Nursing Councils, they're all comes under the professional regulators who will regulate regarding the medications administration, even regarding the supply, dispensing, storage, administration. All those things comes under the professional regulators, as well as covered in the legislation, such as in India we have the Drug and Cosmetic Act 1940, which is revised several times since the time of introduction. The last revision is in 2016. It's an act of the Parliament of India which regulates the import, manufacture, and distribution of drugs in India. The main objective of this act is cosmetics are sold in India safe, effective, and conform the state quality standards. And also there is one more act is there called as Narcotic Drug and Psychotropic Substance Act in 1985. That's also revised recently. So this covers all the drugs which will be causing the habit forming medications. For example, maybe pethidine, maybe morphine. So all sedative drugs or the group H schedules medications comes under this act. So these acts governs the use of medicines and drugs. As a nurse, you should be aware of the areas of legislation that may impact your professional practice in relation to medicine management. It looks very simple here on this slide. During my present preparation, I was going through all the legislation, each clause. It is huge. It is everything is covered. Whatever the medications will be distributed in India, even latex, everything will be covered under these laws.
So Rajendra, I think just adding just one more point to add on to the previous slide. There is the Ministry of Health has got so the main regulatory body is called the Central Drug Standard Control Organization, and under which all these narcotic act and all that comes under. So the main body is the Central Control Standard Organization. That's the main body. Sorry, carry on.
Okay, thank you. So again, as we mentioned regarding the drugs, so we have the different schedule in Ireland, and in Europe we have the different schedule 1 to schedule 8 drugs, whereas in India we have the schedules A to Y. So there are nearly 27 schedules are there. 25 schedules in India. Among that, for nurses, it's applicable one is the schedule H and H1. Almost all 99.99 medication what is sold in the pharmacy covers under that law. And please remember, only the registered nurse, registered medical practitioner at the moment only is allowed to prescribe the medication, and nobody is allowed to prescribe, even to transcribe. So there are few medications. All the medication which is sold in the general market are categorized into the three. One is general sale, pharmacy only, and the prescription. That is, general sale means anybody can go to the medical shop and they can get the medication. Only the few medication. For example, if you want to go and if you want to buy the cough syrup, yes, of course, you can go and get the Benylin cough syrup. No need of any prescription. But if you want to take some medication called as Zyrtec or any other over-the-counter medication, it needs the advice from the pharmacist. And apart from that, any medication categorized under the Schedule H and H1. I know it's a bit confusing now at the moment, but if anybody is interested, I can send the list of medication comes under the Schedule H and H1. Let me know at the end of the presentation, please. So most of the medication what's sold in India comes under the third category, prescription only. So these medications are available only by the prescription. So who can prescribe the medication? That is registered medical practitioner, registered dentist. But in India, I'm not sure exactly whether still it's implemented or not, registered nurse prescriber. But here in Europe and in Ireland, UK and Ireland, we have the designation called as registered nurse prescriber, that is called as RNP. I'm also one of the RNP. I'm practicing as a registered nurse prescriber in Ireland more than 10 years now. So to get this qualification, we have to complete the level 8 certificate course in nurse prescribing to practice as a nurse prescriber. So as a nurse, I'm allowed to prescribe this set of medication, not all the medication, but most of the medication I can prescribe within my limitations. And there is a few regulations are attached to that one. So understanding prescription and your responsibility. So in few terms, in few words, I can say that one is all prescription must be clear, legible, okay, and it should not cause any kind of confusion. It should be clear and should be written in a permanent ink. So what are things prescription should include? That is prescriber details, patient details, and it's more ideal to write in a generic form and the additional requirements. So prescribers means the person who prescribed, especially the medical practitioner, should sign the prescription clearly. Date of the prescription should be included. And if the registered medical practitioner, then their IMC medical council number should be included in that one. And if the registered nurse prescriber means their registration number also should be included. And the patient details also should be clearly highlighted in every prescription. That is their full name, date of birth, and the address wherever it's possible. And it's more ideal to prescribe in a generic form. For example, ciproxin. Ciproxin is a company name or it's a proprietary name. So, but the generic name of the ciproxin is ciprofloxacin. So wherever it is possible, it's more ideal and it's recommended to write the generic form of the medication to avoid the confusion. And also it helps, especially in the government setting, saves the money remarkably. So I think now in India, we have so many generic medical shops. Why they're cheap? Because it's produced under generic name and anybody can produce under the guidance of the Ministry of Health. Whereas the commercial one, they'll add extra tax, additional money they have to spend regarding the ads. So everything will be there recovering from us. So ideally, always it's better to write generic name. Generic one is for the safety, another is for the budgetary purpose. In this, they have to include the form, that is, it's oral, IV, IM injection, or the suspension, everything they have to mention, the quantity, strength of the medication, dosage, what should be the dosage. Example, paracetamol means, okay, 1 gram or 500 milligram. Frequency, it's a QDS or a TDS, and what should be the route, PO, PV, IV, or the PR, everything has to be clearly mentioned. And if it's some of the medication as required, that is PRN medication also should include the clear dosage within the next 24 hours. Additional requirements, every in your drug cardex, always there should be allergy status. So if patient is allergic to any medication, that should be highlighted in the front page of every drug cardex in a red ink, so that whenever you turn when you're going to administer the medications to the patient, yes, patient is allergic to such drugs, example, penicillin. Yes, you can't administer any medications containing the penicillin. So in the first phase itself, we can avoid the drug error. Second thing, that use only approved known abbreviations. For example, MCG, that's micrograms. Try to avoid such type of abbreviations. I know even though it's approved, but causes the confusion. MCG instead of MCG, like for example, 0.25 micrograms instead of that one 0.0. It comes in a milligram, so that will be more ideal one. And if it's instead of writing OD, it's always advisable to write once daily instead of OD. The maximum daily dose of medicine for PRN medication also should be included. And statement regarding the medicine will need to be crushed. For example, any medication comes with a label MR means SR sustained release, MR means modified release, or entry coded. Those medications should not be crushed because the metabolism of the medication will be altered, as well as the most of the medication will be destroyed in the stomach with hydrochloric acid, as well as it causes the other GA upset. Details of the medicine should be discontinued. When the medication should be discontinued. If an antibiotic has been prescribed, yes, for how long it has to be? For 7 days, 10 days. There should be dead end when to stop the medication, and the review date for the medication also.
Sorry, Rajendra, wait for me.
Okay.
I think there's been an interruption. Babu, can you hear us now? Babu, was it disconnected before?
Yes, it was disconnected for, I think, for 5 minutes. He was trying to correct it. Now we can see the slide called additional requirement. I think we missed a few slides before this.
Right.
Okay. Sister, what was the last slide you have seen?
Prescription details.
Yes. Okay. Start from here.
Okay, can you start from there?
Yeah, no problems.
Okay.
From here?
Yeah.
Okay. So prescription details. So what are things should be included in the prescription details? One is prescriber detail. The person who prescribed the medication, that is a medical practitioner. Within the prescription, there should be a clear signature, date of the prescription, and their medical council number. And if the nurses are prescribing, that's not applicable at the moment in SS hospital. But in the future, wherever the registered nurse practitioner or registered nurse prescriber comes, that include the nursing registration number within the prescription. And also, it should include the patient full name, date of birth, and address on every prescription. And wherever it is possible, it's more safe and advisable to write the generic name of the medication. As we mentioned earlier, I think it's disconnected. For example, ciproxin is one of the ciproxin, or norflagil. So there are most common medication. Just example I'm saying. So Dolos 850, one of the common medication also. So instead of Dolos 650, instead of writing Dolos 650, just to write paracetamol. That's the most safest way to write. And also patient can save a lot of money. So every company charge a different rate, but if you give patient buy the generic medication, saves a lot of time, money, as well as it's more safer way of administering the medication, prescribing the medication. So in generic medication, it's always advisable to write the medication in a generic form, like paracetamol, ciproxin, instead of ciproxin, ciprofloxacin. So other points included is in what form you are prescribing the medication. For example, patient is on the NG tube. You can't prescribe the medication with a tablet form. Ideally, it should be in suspension form. So you have to write suspension in its available form. For example, flagyl, or that is metronidazole suspension. So you have to write clearly quantity of the medication, strength of the medication, that is what is the dose, and what should be duration, frequency, and route of the medication. And also, if sometimes it's not doctor want to write only the brand name of the medication, which may not be available in the generic medical shops. In that case, doctor has to write do not substitute, only deliver the particular branded medication, only in certain circumstances. And PRN medication, if you're writing, what do you mean by PRN? That is whenever it's required. But if the doctor prescribes the paracetamol PRN, whenever I want, I can't take. So there is a maximum 4 grams only I can take in 24 hours. So that has to be clearly mentioned in the PRN prescription. Sorry. Then what are the other additional requirement for the prescription? One is in the first page in the drug cardex, should be in the first page itself, it should be mentioned what is the allergy status of the patient. If allergic to any medication, so doctor has to take the details from the patient, mention yes, patient is allergic to so and so medication, so that when the nurse goes to administer the patient administer medication, nurses we can see that one, yes, patient is allergic to this medication. If it's not written before administering every medication, it is our responsibility to ask to the patient, yes, are you allergic to any medication? If patient says something, go through the each medication what is prescribed in the drug cardex and try to withhold the medication and not to administer that such medications, and also use only the approved abbreviations. And also what is here in the fourth point, the statement regarding the medicines need to be crushed. Few of the medication we can't be crushed, so in that case it should be suspension form or any other forms. As I mentioned earlier, for example, you can see the abbreviations for example, dimicron MR. MR means modified release, SR means sustained release, or any medication come, for example, aspirin, neosporin, entry coated. So such medication should not be crushed because that altered the absorption and metabolism of the medication, as well as it causes the GA upset, and also it reduces the most of the medication will be destroyed in the stomach with hydrochloric acid. Okay, so others are self-explanatory here. So dispensing, supply and administration of the medication. Can everyone see this one? Can hear?
Yes, yes, we can.
Sister, please let me know if any technical error, please.
Yes, yes, I will.
Thank you very much. Thank you. So one is who can dispense the medication and who can supply and who can administer the medication. There is two roles. For example, pharmacists have a role of dispensing the medication. That is their role. But they can't administer the medication. Their role is limited up to the dispensing medication only. Once they dispense, their role is finished. They can't come to the next stage of medication administration. So they can't administer the medication to patient, whereas nurses and doctors can receive the medication, especially nurses can receive the medication and administer the medications. So under the Narcotic Drug and Psychotropic Act 1985, controlled drugs, mainly known for their psychotropic characteristics, have been categorized into distinct group of medications. These medications with additional controls such as record keeping and storage are based on the active substance of the drug, their medicinal value and potential for the misuse. So this act directs us the level of control and restriction of these drugs. Really, I'm extremely keen to get feedback from all of you. What are the regulations or local policies are there in terms of the controlled drugs, how you are storing, how you are taking out the medication from the controlled drug press and how you are administering, and what are the restrictions are in place in the SS hospital. Really, I'm keen to know at the end of the session. So here I'm going to skip 5-6 slides. Tipuswami is going to cover this one at the later stage regarding the MDA, that is the Misused Drug Act. All the drugs such as morphine, pethidine, fentanyl, all comes under this one. Okay, so here also I'm not going to cover this one because of the time restriction. So principles of pharmacotherapeutic, this is the one of the most important and required. It's one of the legal requirement also. It's not that it's optional for the nurses. It is mandatory for every nurse to understand how the medications works within the patient's body. No matter what medication you are administering, your IV fluids, yes, you should know how it works. Any complicated medication or any medication, including the blood transfusion or your platelet transfusion, anything you are giving to the patient, you should have the idea how it works within the body. Why it is important? It helps the nurses to assess the appropriateness of the medicine you are administering. And also second one is to develop the education strategies that help the patient to understand the action of the medicines that has been prescribed to the patients. How is the medication management plan can be created and implemented, and its importance to adherence to the medication management plan. and also the importance of reporting the both effectiveness as well as its side effects. If I, as a nurse, if I administer even the doctor prescribed me some medication, and if I administer to the patient also, I should have the idea or the knowledge regarding that medication. Yes, what is that medication? How much dose is required? What is its side effects? What is the expected benefits of that medication? So if there is a side effects, how to monitor those side effects? It is the nurse's role. Without understanding the pharmacodynamics of each medication, you can't administer. It's your legal requirement, all nurses. So if I'm administering medication, it is my legal requirement to understand that medication completely before administering. So here we have a few videos, but because of the time, lack of time, I'm not able to play that one. If anyone is interested, please send the email to our GINA group and we'll forward all the study materials. Next topic is safe and appropriate administration of medication. This is the one of the most important slide for me, this one. See, medicine administration is the administration of the medicines to a patient or by a patient for the therapeutic, diagnostic, or prophylactic or research purpose. It's not only as a nurse we are administering the patient. If the patient takes some medication, also patient also responsible and accountable whatever the medications they have taken. I'll explain that one. So as a nurse, if you're administering, you are accountable for all the actions and omissions relating to your role in administering the prescribed medication as a nurse. But if I'm a patient and list of medication has been prescribed for me and I'm not taking that medications properly, and I can't go and claim or I can't go and sue the case, yes, that doctor is treating me, but I'm not recovering well. No, I have to take that medication to work it. If I'm not taking that medication, I'm responsible for that. But as a nurse, if you're not administering that medication, you are responsible. So both patient as well as nurses are held responsible equally in the administration of medication. That is, if the patient after the discharge, patient goes home and the patient is not taking the medication, patient is responsible. If patient is overdosing, patient is responsible. But when they are in your care, if they're taking the medication from the nurses are accountable for the medication, what they administer or what they discontinued. So here till during our student period, we studied only even till recent time, we studied only regarding the 5 rights of drug administration. But now it's revised. Few of like as I mentioned earlier, it's 8 to 12 rights of drug administration, but more comprehensive one is 10 rights of drug administration. One is right patient, right reason, right drug, right route, right time, right frequency, right dose, right documentation, right action, right form, and the last one is right response. So these all are self-explanatory. Just I'll give you a few lines description for that one. So right patient. So how you are going to confirm you are administering the patient medication right patient? So one is check the wristband of each patient. Check the date of birth. Ask the patient. Even though you know the patient, still you need to ask the patient. Okay, what's your name? Okay, what's your date of birth? Don't say that. Okay, okay, XYZ name. Okay, your name is Hanumantappa and your date of birth is 10th of September 1940. Is it right? If the patient is confused, yes. Best way is that you have to ask the patient, okay, what is your name? Even though you know the patient may be your neighbor also. Still ask the person, what's your name? What's your date of birth? That's the best way of identifying the patient. Right reason. For example, whatever the medication you are giving to the patient, you should have the knowledge of that medication. What you are administering is the right medication or not. Is it giving, for example, if the patient have no temperature, no pain, still do you want to give the paracetamol to the patient? No, it's not required. Only if it's really patient is in pain or patient is pyrexia, then give the medication. So whether are you giving the medication with the right reason, it is your responsibility to analyze the same. Right drug, right route, right time, right frequency, right dose. These all are the old rights of drug administration. I'm not going in detail. Whereas the right documentation is most essential. what we say here is that if you're written, you are done. If you're not written, you are not done. So, but what I'm saying that you write what you have done. So if you're administering medication, you have to write, okay, I administered the medication as prescribed in the drug codex. If you're not given the medication, particular medication, you have to mention, yes, why you have not given the medication, what is the rationale behind that one, and to whom you have communicated. Everything has to be documented. For example, if patient is on the Lasix, furosemide, and the BP is extremely low. Okay, so you can mention that yes, Lasix is not administered because patient's diastolic blood pressure is less than 90. Okay, and the same has been communicated to the XYZ doctor. Time, date, signature with your registration number has to be documented. Right action, right form of the medication, what I mentioned earlier. For example, if the patient is having the swallowing difficulty, so always preferably you have to go for the alternative form of the medication. For example, so there's so many other, whatever the medication you are giving should be in the right form and the right response. So once you administer the medication, you have to monitor for the patient. Yes, patient is getting the right benefit or not out of that medication, whatever you're administering. Is the patient is developing side effects? Is the patient is responding to the medication rightly? So this all has to be monitored. Again, back to the seventh right documentation. So these are all cyclical during your nursing practice, everyday nursing practice. Hand over to Tipaswamy now.
Okay, thank you, Rajendra. It's very comprehensive. Some of the drugs, when we administer, it's important to know that, like Rajendra mentioned, we are accountable for our actions. Sometimes, like antiarrhythmic drugs, for example, you could probably administer antiarrhythmic drugs, some mild form ones in the ward environment, but some of the drugs you cannot administer them, like inotropes, for example, or stronger antiarrhythmics. So you may need to move those patients to more sophisticated areas like a CCU, ICU, or HDU, or emergency units, because in the ward you may not have that facility. So it's important that you don't, just because it is prescribed, you don't go ahead and administer it. You have to think of the safety of the patient. You have to think about safe environment, whether you can monitor those patients. So let's look at some of the administration guidelines. So must be the drugs always must be administered. Medications must always be administered by a competent person and who are legally entitled to do so. In case of delegating to any other person, the registrant is responsible for making sure that the other person is competent. For example, student nurses. So only when the person administering the medication has applied professional discretions, like we discussed, the 8 rights or the 10 rights that Rajendra has explained to you. I'm not going to go in detail again. And then the next thing is the competency exams for administration. So in UK, we have a competency assessment for every qualified nurse. Even though you are a qualified nurse, that doesn't mean that you are competent enough to administer the medication. So we have an additional exams that everybody has to go through, and we must score more than 80% in order for us to go ahead and administer even oral medications, let alone the IV medications. So we have competency assessment for oral medications, intravenous, intramuscular, all form of medications. We have to have a competency assessment, and you have to be familiar with the local policies and use of BNF, or which is called the British National Formulary in UK. In India, I think it's called the SIMS, if I'm right. So
now it's called MIMS, isn't it?
It's called MIMS, is it?
Yeah, it's changed.
Yeah. So sometimes when you administer medication, sometimes it is we can't remember every single drug as a nurse. So it's important that if the drug is not, if you're not aware of the drug, if it's a new drug that is prescribed, you're not quite sure, you should be able to find that MIMS book, go and look for the references. What is it? What is the reason for it? What is the indication for this medication? Can I administer this medication? Is there an interaction with other medications that patient is having? So you should have that copy of the MIMS in your hospital. You should have a local policy in place to ensure that when you're administering medication, you have something to refer to. Competent in formal documentation of administration or non-administration. Like Rajendra said, when you administer a medication or when you don't administer a medication, you need to be able to mention the reason. In UK, in the drug chart, we have a codes. For example, let's say your patient has been prescribed a medication, we have numbers like 1, 2, 3, 4, 5, or a drop down section. So number 1, patient is not in the ward. So now if you put number 1, it's automatically understand patient is not in the ward. Number 2, patient is kept nil by mouth. So you haven't administered the medication because patient is kept nil by mouth. Number 3, patient refused. Number 4, drug not available. So like that, you have a codes, and there is always an additional one called the other, number 5, for example, I of other, and then you mention the reason at the back of the drug chart. So you need to be able to have that system in place in the drug chart where you should be able to document the reasons for administering and not as well as not administering the medications. Next slide, please, Rajendra. Okay, like Rajendra mentioned, crushing the medication can alter the format of the medication itself. Format of the format of the medication itself, and it can alter the therapeutic properties of the medications. It's important that if you are crushing a medication, it has to be endorsed by the pharmacist and making sure that they are allowed you to crush these medications, because you don't want to crush medications because it acts in the wrong place. If you are crushing a medication, you want the medicine to act in the gut, not in the esophagus. So it's important that you get that check verified from the pharmacy and make sure before you crush it, the pharmacy are happy for you to do so when you're administering it. Alternatively, you can get a suspension form of medications. Disguising medications for patients, sometimes it's very difficult. Some patients are confused. It's difficult. They may keep on refusing the medications. It's okay to disguise the medications in a food or a drink. However, you should be able to explain and rationalize why you are disguising the medication in the best interest of the patient. So that need to be documented in the patient's nursing notes, making sure that this is the reason you have to do it. And you must tell the clinician as well as the family or the next of kin, whoever it is, to ensure that this is what we are practicing. All injections must be independently checked by 2 registrant nurses. So in UK, any injections that we administer, whether it is a subcutaneous injection, intramuscular injection, or intravenous injection, all injections are checked by 2 registrant, 2 nurses independently. So if I take a vial of furosemide, for example, I look at the prescription myself, I load the injection, and I go and keep it ready in a tray, and I find my colleague and I ask them to check it. So they are going to go again, check against the drug chart, check the vial, check the expiry date, check the dosage, and then check the patient's allergy status, and making sure that their 2 independently registrants are verified before we administer the medication. Registrants can allow the patient to self-medicate provided they deem to be competent. For example, sometimes the patients want to self-medicate. They want to take control of the patient, their own medications, because they have a way of taking it regularly and they want to keep it that way, which is fair enough. But as long as they are competent to do so. So if they're quite unwell, if they're unable to self-medicate, then it's difficult. So you need to be able to assess those patients and make sure that they're competent enough to take self-medicate patients medications. Unused medicines must be returned to the pharmacy for safe disposal or recycling. So any medications that are left out or expired must be returned to the pharmacy. We should not be keeping them in the stock for in case if another patient comes in for future use. So that's not acceptable practice. It's important to return those medications back to the pharmacy, and it's up to the pharmacy to make the decision whether to recycle those medication or to destroy it. When you return the medication to the pharmacy, it's always a good practice to tell them whether it actually left the hospital. I'll tell you why. If you are in the hospital, if the medication is left in the hospital, every hospital has a policy of maintaining the drug medications at a certain degree temperature. If you are let the person to take the medicines outside the hospital environment, you cannot always guarantee that they have maintained that temperature within the prescribed degree, so whatever the temperature they mentioned on the drug box. So it's important, you should always tell the pharmacist when you return the medication, this patient medication, I'm returning it. However, this is the patient medicine that was brought from home and I'm returning it. If the patient is bringing from home and then you're returning it, that need to be destroyed. But whereas if it's kept in the hospital, then they might reuse it for another patient as long as it is not used. Pharmacy should have a waste management system in place for the medication disposal. Next slide, please. Okay, continuing about the roles and responsibilities. Every one of us are equally responsible for and accountable for our own actions, whether it is you are a prescriber or a dispenser or administering person or following the direction of someone else. So we are responsible for our actions. So we must ensure that you are aware of the policies and protocols that are existing in your place of work. Will be aware of the actions and they should be taken in their practice or their patient safety is compromised. So you should be able to you should be aware of the safety parameters within the clinical settings. When something goes wrong, for example, digoxin, when you administer medication, you should be checking the pulse before you administer medication. If the patient goes into bradycardia, you should be able to address those bradycardia. You should be able to put the patient in a cardiac monitor, record an ECG, record the vital signs. See, it is a common knowledge. If you're administering the medication, you're not just giving the medication, ditching it out, and anyone can do that. But you have to have that background knowledge of making sure that if I'm administering medication, if something goes wrong, what am I going to do? Have I got all those equipment that need to be there to handle the emergencies? So need to be aware of the safe dose, range, frequency, route of administration, and administration techniques, and side effects, and indications and contraindications. So we'll observe the patient for the side effects and adverse reactions, manage them appropriately, like I mentioned earlier. We'll monitor the outcomes of the treatment against identified treatment plans. So for example,
I think voice is breaking. I think.
What is this?
Can you, sorry, sister, can you mute for me, please?
You want to meet us?
No, mute it for me, please. Yeah, thank you. Yeah. Someone called Bully Singh. Can you please mute? Yeah, thank you. Right. We'll observe. Okay, we'll observe the patient for side effects. You need to watch for side effects of the patient and also treatment outcome. So if the patient is having IV antibiotics, if the patient is no longer apyrexial, we need to be okay. So sorry, there is a lot of background noise. Can you please mute all of you? Okay, thank you. We'll monitor the outcome of the treatment against an identified treatment plan. We'll be aware of the limitations and seek advice and support for the appropriate health professional when in doubt. For example, let's say, a patient has been prescribed an IV antibiotic, let's say penicillin intravenous, and the patient has pulled out the cannula. There is the cannula doesn't, you don't have a cannula anymore. Rajendra, the slide is gone now.
Slide is gone.
No, I can see.
No.
No, we can't see the slide.
No, the
Okay.
slide is
What
gone.
is slide number 40? I'll reshare once again.
Okay. While Rajendra is sharing, I'm going to talk about IV antibiotics. If the patient has been prescribed IV antibiotics, if that antibiotic intravenously is not required, for example, patient has been
someone has disabled actually that one.
Pardon?
Somebody has disabled. Okay. Can you see it now?
Is opening.
Yeah.
Yes.
Yes.
Can you see?
Yeah.
The slide again.
Yeah. So if the patient has intravenous antibiotics, if the patient is apyrexial, then there is no need to give intravenous antibiotics if the patient has been apyrexial 48 hours. However, you cannot independently make the decision as an administering person. So because you are not the prescriber, and it's the clinician's responsible for the patient, who is he makes the decision. So I would go back to the consultant or the junior doctors and say, look, this patient has been apyrexia. He hasn't got a cannula anymore. It looks like he's likely to go home soon. Can we change his IV antibiotics to oral antibiotics? And if they say yes, then obviously you can administer the oral antibiotics. So we have to understand those limitations, that you can only okay. Can you hear us, sister?
We can hear you. Yes, we can see the slide now.
Right. Okay. So making sure that, for example, I don't know how far did you hear about the IV antibiotic story?
Yeah.
You did.
Yes, we did.
Okay, good. Okay. We'll avoid any delegation to others who may not be qualified or experienced to carry out the task. For example, it is a bit unfair to ask a first-year nursing student to go and administer intravenous antibiotics when they don't have the sufficient training and competency assessment done. To be honest, when you're administering a medication along with the student nurse, you must be there directly with the student to ensure that they provide a safe practice. I can share you a very good story. There was this this is a story that happened in UK. One of the ward sisters in the UK was administering a medication for a patient in the treatment room. She was preparing it. It was a nasogastric fee medications. She prepared all the medications along with the student nurse, and the patient also had intravenous medications prepared. So there was on one tray there was an intravenous medication, and on the other tray there was a nasogastric medications. They were both kept ready. The sister may received a phone call at the same time, so sister went to attend the phone call, and then while she was attending the phone call, she called the student nurse and said, "Can you go and flush those medications?" So what the student, the nasogastric medications via the intravenous, and then the intravenous medications via the nasogastric tube. Obviously, patient went into complications and patient died, and both the ward sister and the student nurse lost their registrations, and the student was disqualified, and then the ward sister lost her registration. So it is important to making sure that you have the when you assign the task, making sure that you give a clear instructions and make sure that safety is maintained at all times. Next slide, please. Okay, so roles and responsibilities as a ward manager or a consultant or a head of the institute, it's your responsibility to making sure that all your employees are competent, all your employees are trained, and you have the adequate resources to make sure that they have the references in place, information available, and you need to have a collaborative framework with the pharmacist, all as well as the joint prescribing committee. Wherever there is a medication need to be added to MIMS or your pharmacy logbook, it is important to have that collaborative approach and making sure that a safe practice is being carried out in your clinical areas. So ultimately, it's the responsibility of the head of the institutes to making sure that the policies are in place and the competencies are in place. Okay, so health professionals must consult available clinical references, like I mentioned, MIMS or BNF, when an unfamiliar medication has been prescribed. Next chart, please. Slide. Okay. All new medications must be formally approved by the hospital joint prescribing committee. Prescription must only be undertaken by a legally certified prescribers. The prescriber must make sure that when they're prescribing a medication, they should not be distracted. So as far as possible, they need to be in a quiet place. Admitting doctor or nurse prescriber is responsible for making a comprehensive medical history, including the drug history, and making sure they prescribe it in the drug chart accordingly. Prescriber must use the generic names like Rajendra mentioned. Medication, all medication procurement must be undertaken by the hospital pharmacy. So we cannot ask the patient to go and buy the medications from outside the hospital. It's the responsibility of the pharmacy to make sure that they get the medication from outside and dispense it to the ward. All medications must pass through the quality control test and must be value for money. Pharmacy is responsible for maintaining a stock and monitoring of the quality, integrity, and including the storage, like I mentioned, the temperature of the medications. Each ward should keep a stock of their own medications, including emergency drugs, IV fluids, antibiotics, analgesics, antipyretics, and laxatives and antiemetics. These are some of the most commonly used drugs. So we should have each ward should have a stock of certain drugs. The ward treatment room should have a temperature regulatory system, including medications. In UK, every ward has got an air conditioner to making sure that the temperature is maintained within below 25 degrees centigrade, because that's the maximum temperature that you can maintain the store the medications. All medications must be stored safely and securely. So you should have a lock and key for your drug cabinets. Controlled drugs must have a double locker. So there is a drug cupboard. Within the drug cupboard, there is a controlled drug cupboard inside it. So that needs to be locked as well. So and it should be it should be locked and kept all the time while it is not being used. General guidelines: controlled drug record book must be is a legal requirement. So whenever you have a controlled drug, for example, opiates, morphine, diamorphine, dihydrocodone, tramadol. So these are I don't know how often you use these drugs. So these drugs are kept in a controlled drug book and a cupboard, and we need to make sure that you keep a record of how many, let's say for example, morphine sulfate injections. You got 10 vials in the book. You got it 10 vials from the pharmacy. You administered 1 vial to the patient. So you need to write how much you administered. So let's say a patient has got prescribed 5 milligrams of morphine, and you only got 10 milligram vial in your control drug cabinet. So you given 5 milligrams given. You write the patient name, how much dose you gave, 5 milligrams, and what did you do with the other 5 milligram? You have to say it's either wasted or you have to waste it once you open the apple. So you have to waste whatever you write down the wasted amount as well, and 2 nurses has to sign it, and you write the balance. So you had 10 vials, you used 1 vial, and there is 9 left. So that has to be clearly and legibly documented on the controlled drug books. All medications must be supplied by a hospital pharmacy for the duration stated. During discharge time, a minimum of 2 weeks supply of medication must be given to the patients. The reason we say provide 2 weeks supplies, that would give the patients an adequate time to get any follow-up medications from their local pharmacist. Compliance aids like a dosage box or a blister packs, I'll show you the pictures in a future slides, that can be used as an aid if the patients are unable to self-medicate, or if they cannot work out when to take what medications and all that. So that can be added into the dosage or a blister box. So hospitals are required to comply with the regulatory authority. So let's say, for example, a medication as a faulty medication. There's been an issue with the medication that was supplied by the manufacturer, and they just suddenly found out that there has been a problem with this medication in particular. So that's why they have these batch numbers on each drugs, vials or blister packs. So if there is a fault, it's the manufacturer's responsibility to inform that these are the drugs that we need to be called back. So they need to call back. When they contact the hospital pharmacy should circulate to the whole message to the whole ward and make sure that you return all those medications back to the pharmacy and send it back to the manufacturer and investigate for any errors. So we need to cooperate with the manufacturing companies. Medication directions. When you administer medications, it's important. See, one of the most commonly done errors in Indian settings is like when you administer a medication, when you dispense a medication, there is no clear guidelines about when to take, how to take it, how many tablets you can take. So here is a label on a medication box on the right hand side. It says here, keep out of reach of children 30 codidromol tablets. It says here take 1 or 2 tablets 4 or 6 every 4 to 6 hours when required. It says the patient's name there and the date as well, and how many tablets has been supplied. And on the left hand side here, you give a clear instructions to the patients, the list of medications on the left, and then the instructions how often they should be taking it. What is missing here is the number of days they should be taking it. So the name of the tablet, number of times they have to take, and how long they have to take it. So it's about providing the transparent and clear instructions to the patients in a written form, because it's very difficult if you explain to somebody verbally, especially when they're unwell. It's very difficult if they have more than, well, look at the number of medications they're on. So it's difficult to remember every single one of them. Okay, next one, please. Appropriate medicines. A medicine may be considered appropriate when there is a clear clinical indication and agreed. Is it your slide, Rajendra?
Yeah.
Okay, go for it. Sorry.
It's okay. Thanks. Thank you. So next one is appropriate. When do we consider medication is appropriate to the patient to administer? So that is, there should be a clear clinical indication and agreed purpose for the medication regime. So there should be clear indication. Whatever the medication we are administering to patient, you should have a clear indication. For example, if the patient is the urine culture shows patient is resistant to the macrodontin, so then there's no point in giving the same medication which is patient is resistant. So there should be clear indication. Okay, patient is sensitive to the particular medication. Okay, give for example meropenem. So patient is a blood culture or urine culture sensitive to the meropenem. Give the medication with the meropenem instead of the macrodontin. Next one is medication is appropriate for the condition as I mentioned, and also patient has no allergic reaction or sensitivity to particular medication, then only it's considered safe. If the patient is allergic to any medication, don't administer that. That's not appropriate medication to the patient. There's a difference between allergy and sensitivity. For example, if we give the amoxicillin along with the chloronic acid that is augmented, if you give to the patient, few of them, they're not allergic to that one, but they are extremely sensitive. The moment you give, within a couple of hours, they'll start developing diarrhea. So that means they don't have allergy, but they're sensitive to medication. So if the patient don't have any allergy, a patient is not allergic to that particular medication, and the patient is not sensitive to that particular medication, that medication is considered as appropriate also. The dose should be correct. Always start with a low dose and gradually step up. It can be analgesics, or it can be any other applicable to almost all the medications. Go in a ladder way. There is no and also there is no clinical significant drug to drug or drug release or drug condition contraindication. For example, if you're giving the certain drugs, for example, clarithromycin, one of the commonly used antibiotic, which you can't be given along with the cholesterol lowering medication. Either it can be simvastatin or atorvastatin. Ideally, we need to stop those anti-cholesterol medications or cholesterol lowering medications when you're starting with the clarithromycin. So there is a drug-to-drug interaction. We need to stop that one. Or if the patient is on digoxin and if the potassium level is very low, then we can't administer the digoxin. We have to withhold the digoxin because it increases the toxicity of the digoxin. So there's a drug-to-drug interaction or some kind of patient condition to drug condition reaction. And also there is no duplication with another medication. Sometimes, as I mentioned, it's always safe to write with a generic name so that we can avoid the duplication of the medication. Certain medication we won't be able to understand the trade name, and it can double up. The medication is acceptable and practicable for the patient is considered as more appropriate. Here is the most appropriate practice in daily nursing or even in the medical also, called as medicine review. What is this medicine review? It should be carried out every day in everyday practice. That is, it's a structured critical examination of the patient medicines with the objectives, that is reaching an agreement with the patient about the treatment, optimizing the impact.
Rajendra, sorry, hold it. I think the Davangere team has lost a connection. 1 second.
Okay.
Sister, ಇನ್ನ ಟೈಮ್ ಎಷ್ಟಿದೆ ನಿಮಗೆ?
Another 10-15 minutes maybe. They said they have a lot of questions to ask you.
Okay. In that case,
Okay,
I think
we'll skip
wind
the
it up.
slides completely.
Okay, fine.
You can ask the questions instead.
Yeah, better. Okay.
ಈಗ connect. Yeah. I'm trying to admit you. Admit ಆಗ್ತಾ ಇಲ್ಲ.
Some problem with our system, I don't know. He's trying to do it.
Okay. Rajendra, I think they only have 10-15 minutes.
Yeah, just I'll skip the few slides and I'll within
No.
1-2 minutes.
Hang on, Rajendra. They have a lot of questions, so I think we.
Okay, then we'll skip the whole slides. Then we'll come to question and answers.
Yeah, exactly.
Yeah.
Sister, can you see us now?
Oh, we can't.
Whether they can see?
Not yet.
He's saying wait for a minute. He's doing something.
Okay. Right. Bunny.
Not it logged in.
Later, in connection, internet problem, then the laptop problem.
ಸ್ಟಾಫ್ಗಳು ಅವ್ರಿಗೆ ಲಿಂಕ್ ಇದ್ರೆ ಅವ್ರ ಲಿಂಕ್ ಇಂದನೇ ಜಾಯಿನ್ ಆಗ್ಬೋದು ಫೋನಲ್ಲಿ ಅವರೆಲ್ಲರೂ.
And also, whoever is the staffs, they can start asking question if they have any. Whoever is logged in.
ನಿಮ್ಮ ಫೋನಲ್ಲೂ ಕೇಳ್ಬೋದು ಬೇಕಿದ್ರೆ. I don't know. Yeah. ಮೈಕಲ್ಲಿ ಆಡ್ ಮಾಡಿ ಬೇಕಿದ್ರೆ ಮೈಕಲ್ಲಿ ಕ್ವಶನ್ ಕೇಳಿ. Then when I talk, you hold the phone to the mic.
Okay, fine.
So then they can hear the answer.
Okay, fine.
Video call ಮಾಡಿ.
Rajendra, slides ತೆಗಿತೀರಾ?
ಹೌನ್ರಿ.
Naresh, question. Link ಬಿಡು, ಈ ಕ್ವಶನ್ ಕೇಳ್ಕೊ ಹೇಳ್ತೀನಿ.
Whoever is logged in, they can ask question directly. You can unmute your mics and you can speak.
Naresh, you can ask questions from your login.
Hello, sir. Hello.
Yeah, you can.
ಹೇಳಿ Naresh.
ಕೇಳಿಸುವಷ್ಟು ವಾಯ್ಸ್ ಮೈಕ್ ಬರ್ತಾ ಇದೆ ಬಟ್ ಅವ್ರ ವಾಯ್ಸ್ ಕೇಳ್ತದೆ ನಮಗೆ.
ನರೇಂದ್ರ.
ಹೇಳಿ.
ಹಲೋ ಸರ್.
Yes, we can hear you, Naresh.
Boss.
ಹೇಳಿ sister.
Can you hear me?
Yes, I can. Yeah. Naresh, can you mute your mic on the other side? Yeah. Okay. ಬೇರೆಯವರೆಲ್ಲ ಮ್ಯೂಟ್ ಮಾಡ್ಕೊಳ್ಳಿ.
Swami, that won't be possible. If everyone turn on their mobile, then there will be a lot of disturbance.
Naresh, what is the question?
So you mentioned, especially mentioned for the reason, sir.
Sorry, what is that, Naresh? Come again.
So, shall we mention work pressure? If we have assess the reason we have mentioned work pressure, sir, that is right or wrong, sir?
Work. Yeah.
That is right or wrong, sir?
Work pressure.
That is legal opinion or illegal, sir?
So, did you say work pressure ಅಲ್ಲಿ ಮಿಸ್ಟೇಕ್ ಆಗುತ್ತೆ ಅಂತ ಹೇಳಿದ್ರೆ ಅದು ಹೇಳ್ತಾ ಇದೆಯಾ? ವರ್ಕ್ ಪ್ರೆಷರ್ ಅಲ್ಲಿ ಮಿಸ್ಟೇಕ್ ಆಗುತ್ತಿಲ್ಲ ಅಂತ. Okay. How do you overcome that problem? Is that the question?
Swami, hello, Swami.
Yes, sister.
Swami, what is this doubt? I think work pressure ಇಂದ ನಮಗೆ mistake drug error ಆದರೆ are we responsible for that? What the legal application will be there for drug error during work pressure? Is that your question? Yes, that is his question, Swami.
Okay, Rajendra.
Okay, technically, if any nurses were under pressure, if they're not able to carry or delegate their responsibility, they can't administer the medication. If they're feeling this because of the work pressure, I can't administer the medication. Don't administer the medication. Escalate the problem to the line manager or the nursing supervisor. Yes, I'm extremely busy in my department. I'm not able to carry out my roles properly and safely. I need extra help. But if you're thinking that yes, because of the pressure, if you're not able to administer safely, don't administer, don't harm the patient. Or prioritize your work. What is most priority? Always in nursing studies, we are studied like priority. What is priority? On the basis of priority, in a safer way, you have to deliver the care. Wherever you need help, ask for the help. Wherever you need to escalate the problem, you need to escalate it. But as we say, don't harm the patient. If you harm the patient, you are responsible. No matter how much you are under pressure, if you administer the wrong medication, you are responsible. There is no excuse for that one. So you have to analyze how best you can deliver your care.
Naresh, ಗೊತ್ತಾಯ್ತಾ? Okay, basically, ಈಗ let's say, okay, ಈಗ you are under work pressure and you have so many drugs to do and you have so many other things to carry out at the same time. Okay, you have 4 admissions, you have a sick patient, you also have 20 patients to do the drugs, alva? So you have to prioritize what is important, what is most important. You need to have somebody to look after the sick patient. You got 5 admissions. Are those patients stable enough where you can carry out your drug rounds and then you can go back and look at the admissions? So if you got too many things going on at the same time, that you only got 2 pair of hands. All you have to do is get someone to help you while you are doing the drug rounds. You call your supervisor and say, look, I got drug rounds to do. I got 5 admissions. I got a sick patient. I need some help here. Okay. Otherwise, I'm unable to carry out the drug administrations in a safest way. That is why we call it as we say we fill the incident forms, incident reporting. Okay. Pardon?
If the supervisor not send the helping, if mistake will happen, who is responsible?
If you have informed the supervisor, if you inform the supervisor, she is also equally responsible because she has failed to provide you the support.
Okay. Thank you.
Yeah.
Swami.
Yeah.
Actually, what is he was asking, if drug error happens with the work pressure, is the hospital take the responsibility of that error legally?
See, everybody, they have to, you have to realize whether it is a individual person's is it a one-off incident that the person has carried out this mistake because of the work pressure, or is there been a series of errors by the staff member? They keep on doing the same mistakes again, then it becomes a training issue. If it's a one-off incident, then you still have to investigate whether it's a near miss incident where they missed the medication or they administered a wrong medication. You still have to investigate it. So that's why the incident reporting is important, and it is the responsibility of the senior nursing members of the investigation team to find out the outcome of a which is what we call it as a root cause analysis. What was that was mainly leading to this drug error? Was it the work pressure, or is it the person who got it wrong?
Yeah, we have to investigate it properly.
Oh,
yeah.
Correct.
Okay. The other question is, unlike UK, we don't have a clinical pharmacist here.
Yes.
Ward pharmacist yaru baradilla.
Houdu.
In UK, we have clinical pharmacists, but we don't have here. That is another reason for the drug error here.
Yes.
Prescription is very poor. That is another reason for drug error.
Yes.
So prescription here, SHO also writes the prescription. Sometimes they leave the prescription. They ask to write the prescription for nurses.
No.
Yeah. That's
you
what
should.
happening here. That is the other thing. That's what I want. We don't have, PPPGs, what is it, the protocol, policies, guidelines, those things. I think we need to have those things properly and hand over to the medical staff those things.
Even medical staff don't have. Can you provide those?
ನೀವು ಆ ಕಡೆ ಬಂದಿದ್ದೀರಾ ನೋಡಿ, ಇದರಲ್ಲಿ ಲಾಗಿನ್ ಆಗಿದ್ದೀರಾ ನೋಡಿ ಸ್ಕ್ರೀನ್ ಅಲ್ಲಿ.
And please
We can go through. ಅದು ಕರೆಕ್ಟ್ ಮಾಡ್ಕೊಳ್ಳೋಣ. Okay, fine.
ಸ್ವಲ್ಪ ವಿಡಿಯೋ ಆನ್ ಮಾಡ್ತೀರಾ ದಯವಿಟ್ಟು?
ಇದೆ.
ವಿಡಿಯೋ ಆನ್ ಮಾಡಿ ಸಿಸ್ಟರ್.
ವಿಡಿಯೋ ಆನ್ ಇದೆ.
Yes.
Right. Okay.
So
ಈಗ
as per the
ನನಗೆ
law,
ಗೊತ್ತಾಯ್ತು. ನನಗೆ ಗೊತ್ತಾಯ್ತು.
ಕೇಳ್ತಾ ಇಲ್ಲ.
ಕೇಳಿಸ್ತಾ ಇದೆಯಾ?
Swami, we can't hear you, no?
ಹಲೋ, ಕೇಳಿಸ್ತಾ ಇದೆಯಾ?
ಏನಾದ್ರು ಮ್ಯೂಟ್ ಆಗಿದೆ.
ಹಲೋ ಹಲೋ.
We can hear you, Swami. I think they can't hear.
They have a problem.
They have a problem on that side. Now I think try it now.
ಹಲೋ, ಕೇಳಿಸ್ತಾ ಇದೆಯಾ ಸಿಸ್ಟರ್?
No, it's keep fluctuating.
ಇಲ್ಲ ಇನ್ನೊಂದ್ಸಲ ಲಾಗಿನ್ ಆಗ್ಬೋದ್ರಿ, ಅದನ್ನ ಲಾಗ್
Hello,
ಔಟ್
Swami.
ಮಾಡಿ.
ನೀವು ಮಾತಾಡೋದು ಕೇಳಿಸ್ತಿಲ್ಲ ಇದ್ರಲ್ಲಿ.
ಓಕೆ, ನಿಮ್ದು ಇನ್ನೊಂದ್ಸಲ ಲಾಗ್ ಔಟ್ ಆಗಿ ಲಾಗಿನ್ ಆಗಿ
ಕರೆಕ್ಟ್ ಆಗಿ ಬರ್ತಾ ಇದೆ.
ಮಾಡ್ತಾ
ಈಗ ಬರ್ತಾ ಇದೆ.
ಇಲ್ಲ ಬರ್ತಾ ಇದೆ, ಬಟ್ ಲಾಗ್ ಔಟ್ ಮಾಡೋ ಅವಶ್ಯಕತೆ ಇಲ್ಲ.
Yeah, it's okay.
You're not audible.
Okay, basically ನಿಮ್ ಕ್ವೆಶ್ಚನ್ ಗೆ ಆನ್ಸರ್ ಏನಪ್ಪಾ ಅಂದ್ರೆ, under no circumstances nurses should be prescribing medications for in the drug chart.
ಅದೇ ನನ್ಗೆ ಕರೆಕ್ಟ್. ನನ್ಗೆ ಇದು ಪ್ರೋಟೋಕಾಲ್ಸ್ ಪಾಲಿಸೀಸ್ ಅದೆಲ್ಲ ಸ್ವಲ್ಪ ಇದು ಇದರಲ್ಲಿ ಯೂಟ್ಯೂಬ್ ಅಲ್ಲಿ ಸಿಗುತ್ತಾ ನೀವ್ ಹೇಳ್ದಂಗೆ?
It's individual to each hospital system, but if you want, we can send the one copy just as a matter of reference.
ಹಲೋ,
ನಿಮ್ಮ ಹಾಸ್ಪಿಟಲ್ ಇಂದ ಒಂದು ಜಾಯಿಂಟ್ ಪ್ರಿಸ್ಕ್ರೈಬಿಂಗ್ ಅಂಡ್ ಫಾರ್ಮರ್ ಕಮಿಟಿ ಅಂತ ಇರುತ್ತೆ. ಅದರಲ್ಲಿ ನಿಮ್ಮ ಮೆಡಿಕಲ್ ಡೈರೆಕ್ಟರ್, ನರ್ಸಿಂಗ್ ಡೈರೆಕ್ಟರ್, ಫಾರ್ಮಸಿ ಇನ್ಚಾರ್ಜ್ ಇವರೆಲ್ಲ ಕುತ್ಕೊಂಡು ಯು ಹ್ಯಾವ್ ಟು ಡಿಸೈಡ್, ಮೇಕ್ ಎ ಲಿಸ್ಟ್ ಆಫ್ ಥಿಂಗ್ಸ್ ದಟ್ ಆರ್ ನೀಡೆಡ್ ಇನ್ ದ ಪಾಲಿಸಿ. ಅಡ್ಮಿನಿಸ್ಟ್ರೇಷನ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಪಾಲಿಸೀಸ್ ಅಂತ ಒಂದು ಪಾಲಿಸಿ ಇದೆ.
ಯಾಕೆಂದ್ರೆ we have a little policies for this NABS and all, Tippeswamy.
Yeah.
But we don't have really proper policies. You know that we don't have a double checking and double checking thing is not there for medication administration.
Well, these are the things that you should be implementing it.
That is what. So I think if you have a basic policies, we can convert into our local need.
ಹೌದು.
So ಅದನ್ನ ನೀವು ಕಳಿಸಿದ್ರೆ ಕಳಪ ಸರ್ ಕೊಟ್ಟು, so we can do that. ಅಯ್ಯೋ ಏನು ಆಗ್ತಾ ಇದೆ ಗೊತ್ತಾಗ್ತಾ ಇಲ್ವಲ್ಲ. ಕೇಳಿಸ್ತಾ ಇದ್ವಾ? ಈಗ ಕೇಳಿಸ್ತಾ ಇದೆ.
ಓಕೆ, ಹೇಳಿ ಸಿಸ್ಟರ್. ಈಗ ಬೇರೆ ಏನಾದ್ರೂ ಕ್ವಶನ್ಸ್ ಇದೆಯಾ?
ಏನಿದೆ ಕೇಳಪ್ಪ. ಮತ್ತೆ ಯಾರಿಗೆ ಏನಾದ್ರು ಕ್ವಶನ್ಸ್ ಇದೆಯಾ? ಯಾರಿಗಿರೋ ಕ್ವಶನ್ ನೀನೇ ಕೇಳಪ್ಪ. ಕನ್ನಡದಲ್ಲೇ ಕೇಳು, ಪರವಾಗಿಲ್ಲ. ಕೇಳಿಸುತ್ತ ಅವ್ರಿಗೆ? ಈಗ ಕನ್ನಡದಲ್ಲೇ ಕೇಳಿಸು. ಕೇಳಿ, ಎಲ್ಲಾರ್ಗು ಕೇಳಿ. ಮುಗಿತು.
So, emergency situation, can we administer the drugs without orders, nurses?
No.
Yes, you can administer certain emergency circumstances only medicines. Can you administer emergency medications without prescription?
If they're qualified.
If they're qualified nurses, yes, you can.
Specially trained. Otherwise, in any situation, no emergency medication can't be prescribed without administered without the prescription or verbal directives.
So, for example, if in case of resuscitation scenario, cardiac arrest scenario dalli, ಅಥವಾ say for example, so let's not go for cardiac arrest. You will get the cardiac arrest by then anyway. But hypoglycemia aitu patient ಗೆ, you need to give dextrose. If it is not prescribed, as long as the blood sugar is less than so and so, you are allowed to administer certain medications. Dextrose ಕೊಡಬಹುದು IV ಅಂತ, as long as you get a verbal order from the doctor. ಆಯ್ತಾ? Then they can come and retrospectively write it. If the patient is pyrexial, you can administer paracetamol and then ask the doctor. But you need to still let the prescriber know that the patient is pyrexial and you're going to administer paracetamol. And if he says yes, then you can administer it with the verbal instructions. If the patient run out of IV fluids, for example, somebody forgot to re-prescribe the IV fluids, you can ask the doctor to re-prescribe it. Then they can come back and re-prescribe it within the certain time. So yes, some medications can be administered with the verbal orders.
So what are the medications?
One clarification: if it's a verbal order, means for example, if doctor is there somewhere else and he want to order verbally over the phone, so then there should be an additional nurse to take the information. For example, like a doctor phone made, okay, then you administer the XYZ medication. Okay, so I will be as a nurse, ನಾನು phone ತಗೊಂಡು okay, ciprofloxacin, administer this ciprofloxacin, that is the instruction by the doctor. Then I'll give the phone to another nurse to clarify what I heard is the right medication or the right instruction. So that has to be confirmed by the other nurse, and same thing has to be documented. And the doctor, there should be a protocol for everything. Actually, ಹೇಳ್ಬೇಕು ಅಂತಂದ್ರೆ ಅದಕ್ಕೆ.
Actually, we have a, hello, can you hear me?
Yes, yes, sister.
Actually, we have a policy called callback policy. In that situation, if the doctor is not in the ward, he is somewhere in the hospital. In emergency situation, we ask someone to call the doctor. He may say patient is convulsing. And if we want to give an anticonvulsant, we can't really administer without the doctor's order, isn't it? So what we do, we ask someone to call the doctor to see this patient is convulsing, what drug I have to give and the dosage, everything he can tell on the phone. So she will write in the nurse's chart. So a call received from so and so, so he advised like this, and they administer the drug. And when he comes to the ward, he has to prescribe that one. That is callback policy. We have that one in India.
Okay. So same policy here also, sister, but only thing that whatever, for example, like a sister, or if when the doctor calls back to particular nurse, or when the nurse calls the doctor, and doctor will give the telephonic order, the same order should be heard by the another nurse also, just to avoid the error.
Yes, yes.
So the two nurse has to
that
sign.
is difficult because we have shortage of nurses.
Shortage
no?
of staff.
So
Because sometimes.
Sister, one more thing important andre, for example, say you got a patient who's admitted with convulsions, okay?
Yes.
Okay. You have, as a qualified nurse, it is your responsibility to make sure there is an anticonvulsant prescribed on the PRN side when the patient is admitted. Okay. So it's important to anticipate these things as a nurse. So you are the one who knows the patient better. So if the patient has got pyrexia, then if the paracetamol is not prescribed on the PRN side, then it's your responsibility to remind the doctor to make sure there is a paracetamol that needs to go on the PRN side. If the patient is constipated, there is a laxative that's prescribed on the PRN side. So don't just leave it everything to the doctors. You have to remind them. If you understand the patient condition, then you know what medications are needed.
Yeah.
That is we also have a role to play.
Oh, yes, that's right. Okay, thank you. Any questions? ಅದೆಲ್ಲರಿಗೂ ಗೊತ್ತು. Don't ask that. ರೇಷಿಯೋ ಇಂಗ್ಲೆಂಡ್ ಅಲ್ಲಿ ಇದ್ದಷ್ಟು ರೇಷಿಯೋ ಇಲ್ಲಿ ಇಲ್ಲಲ್ಲ, ಅದಕ್ಕೆ ಏನ್ ಮಾಡ್ಬೇಕು?
Sister, we are also facing the same problem here.
I know.
We are facing extremely shortage, especially for COVID sickness.
It's there everywhere in the world.
Staffing issue is there everywhere.
Yeah.
And you guys don't have the same documentations of what we do here.
Oh yes, that we are very poor in documentation, Swami. I'll tell you. We are very poor in
documentation that we do here. It is almost, you only do probably about 10% of what we do.
I know.
So
sometimes what happens here for nurses, they have to do a little bit of non-nursing work, clerical work. Here we have government schemes that clerks has to do, but here nurses has to take that responsibility. And here big problem is maintaining the stock. UK it is not there. We don't count everyday syringe, we don't count stethoscope, this, but here we have to do that. Linen, inventory, everything we have to count and give. That is an extra work. If you compare to UK, that's an extra work here for nurses, Swami, actually. That is another thing. Nurses overloading. And we have to go and stand somewhere for a while, maintaining that register, this register, lot of work. So
what is the nurse patient ratio there?
Oh, different area, different. Don't ask. This is very poor. Don't ask. Yeah, that is there actually, but they struggle, they work, but I think there is a problem with the nurse ratio. But if you know your time management, if you know how you organize your work, and if you know how to prioritize your work, we can manage little bit better than what we always say, no nurses.
Right.
Yeah, that is okay. Thank you very much. Shall we close, guys? Okay, Rajendra, Swami, and Suman, the other person.
Suresh.
Okay. Thank you very much for all three of you. I want really to continue this one. It is really, today's session was very useful, very informative and comprehensive. It was really good session we heard today. And the 6 o'clock in the morning, you guys, so 5 o'clock maybe you woke up to get this ready, isn't it? You are still sleeping. It's afternoon for us. And a winter, you woke up at this time and sit to teach others Indian nurses. It's a really great effort. I really, it's very big appreciation for you guys. Very well, very well. It's a great help you are doing. Thank you very much.
We are following your footsteps, sister, because I do remember when I was doing my nursing, you are there in the neonatal intensive care unit at that stage in CHI.
Okay, CHI.
96, 97.
Okay, have you seen me?
Yes, sister.
Okay.
I worked under you.
All right, okay.
CHI.
Junior.
Okay, I don't know. Okay, I forgot maybe. I don't know.
ಅವಾಗ ಕಳಪ ಸರ್ ಇದರಲ್ಲಿ CHI ಒಳಗೆ he started at that stage or he was working ಅವಾಗ.
Oh, sorry.
ಅವಾಗೆಲ್ಲ ನಾವೆಲ್ಲ ಇದಕ್ಕೆ ಪಲ್ಸ್ ಪೋಲಿಯೋ ಬೂತಿಗೆಲ್ಲ ಹೋಗ್ತಿದ್ವಿ ಜೊತೆಗೆ.
Oh, sorry. ನಂಗೆ ನೋಡಿದ್ ನೆನಪಿಲ್ಲ ನಂಗೆ ಆಕ್ಚುಲಿ. ಕೆಲವೊಂದು ಕಾಂಟ್ಯಾಕ್ಟ್ ಇದ್ದವ್ರು ನೆನಪಿರುತ್ತೆ. ಬಟ್ ನೀವ್ ಏನ್ ಮಾಡ್ತಾ ಇದೀರಿ ರಾಜೇಂದ್ರ, ದಿಸ್ ಇಸ್ ರಿಯಲಿ ಗ್ರೇಟ್ ಜಾಬ್, ರಿಯಲಿ ಗುಡ್ ಜಾಬ್. We learn many things, but I want many aspects to continue we need to learn lot of things from you, Rajendra.
Right.
Actually, this was minimum 4 hours presentation, sister. That is minimum 4-hour module minimum.
ಏನು ಕಟ್ ಆಗ್ತಾ ಇದೆ, ಸರಿ ಕೇಳಿಲ್ಲ.
No, actually, we didn't cover everything. It's at least it takes 3 to 4 hours.
I know. You can cover it in a different session.
Yeah.
Even I think a little bit of clinical demonstration should be better. I don't know, you have a videos. If you have a videos, if you can send it to us, we can just show everyone.
That's fine, no problem. So you can send the email, sister, then we can forward.
Yeah,
so that,
send my email to you. You can do that. Yeah.
Okay, thanks.
Thank you, sister. One more thing.
Thank you, Suresh.
One more thing I would like to end up with this. We, GINA group, Global Indian Nursing Association, we started recently, and also we are having a webinar every other week. So mainly we are concentrating on the nursing students, nursing faculty, and the clinical faculty as well. So last week we had one session and regards to the cardiology, and next week we also having another session which is pressure ulcer prevention and management. So every other week we are having a webinar. It will be only on Saturday. In Indian timings, it started off first 11:30. So it means in India, here in UK time, 5:30. So we have to wake up by 4 o'clock and get ready with this along with our other job as well. So, but still, we are very happy to carry on this one. Thank you very much for your offer. Always we are there to support you. Thank you.
Thank you. It was a great job you guys are doing. Thank you. You are helping nurses.
Actually, we are having created the WhatsApp group for the nursing staffs across the India.
Okay.
So we are going to launch that one today or tomorrow.
Fine.
So that's a WhatsApp group only for one group for the nursing students and one for the nurses.
Clinical nurses. Okay.
So adralli agatantre we'll share the knowledge. There's the like open discussion forum. ಆಮೇಲೆ ಮಧ್ಯ ನಮ್ದು ಎಜುಕೇಶನಲ್ ವಿಡಿಯೋಸ್ ಬರೋದಾಗ್ಲಿ ಅಥವಾ ಎನಿ ನಾಲೆಜ್ ಶೇರಿಂಗ್ ಅದ್ರ ನಡೆಯುತ್ತೆ. No good morning, good night wishes, nothing, no festival wishes, nothing. Only academic.
Okay, fine.
So other link ಕಳಿಸ್ಕೊಡ್ತೀವಿ ಸಿಸ್ಟರ್ ನಿಮಗೆ. So if you are able to circulate in throughout the hospital, that would be great.
Fine. I can do that. I'll do that.
Thanks.
Thank you, Rajendra. Thank you, Swami.
Thank you,
sister.
Thank you very much.
Bye.
Bye. Have a good day.
Thank you. Bye.
Thank you.
Thank you.
GINA members, please can stay back, please.
Okay, thank you.
Shall we log in different ways?
ಇಲ್ಲ ಅವರೇ ಡ್ರಾಪ್ ಆಗ್ತಿರ್ತಾಳ.